Thanks for joining us for Interprofessional Selective Rotation, a year in review. This started as a College of Medicine 2-week optional selective course and a component of a 4-week College of Pharmacy clinical elective course, August 2021 through June 2022. The learning activities include self-paced online learning modules, Unity clinic sessions at Good Shepherd Clinic, and interdisciplinary case-based patient simulations. The announcement as of March 2020 that I've been approved as the director for the course, and it will be a required selective for all fourth-year medical students enrolled in the University of Oklahoma College of Medicine. The description of the selective, a population health curriculum focused on the exploration of health inequity, community health, health literacy, and social determinants of health. Students will participate in interprofessional collaboration with other health professions with the goal of providing coordinated services to patients. Teams will follow a student-led operational approach designed by the Unity Clinic leadership team. The selective goals include students will gain foundational knowledge in interprofessional-based collaboration to teach, practice, and reinforce interprofessional skills such as communication, teamwork, respect, community, and ethics, while serving in roles and responsibilities centered on a population-based, patient-centered clinical environment. Activities are based on the IPEC core competencies. College of Pharmacy and College of Medicine students interact directly throughout the selective at Unity Clinic and through interdisciplinary case-based patient simulations. There's ongoing curriculum alignment for IPE learning experiences involving both colleges, and there's weekly meetings between myself and Dr. Dennis. There's a requirement of 2 Unity Clinic sessions. All clinical encounters are interprofessional and function according to Unity Clinic guidelines. Course evaluations are administered throughout the course to allow for self and group-based reflections of the students' interprofessional experiences. There are 2 team debriefed questionnaires completed at the end of each clinic, structured around the IPEC core competencies. And then there's a pre- and post-assessment of student individual attitudes towards interprofessional collaboration and how perceptions have changed at the end of the course.
So the broad IPEC competencies provide the framework really for the shared learning experiences that all the students have. Specifically, the selective rotation is intended to highlight a number of subcompetencies in each of the 4 domains. There are 3 subcompetencies that are included for values and ethics, 6 subcompetencies for roles and responsibilities. RR2, recognizing individual limitations, becomes really apparent throughout our experience. And RR10, integrating clinical care with public health, is also an area of focus. 6 subcompetencies are also included for interprofessional communication. CC2 and 3 are specifically emphasized for team and patient-centered communication that is open and encouraging to promote common understanding. And finally, 3 subcompetencies are emphasized for teams and teamwork. TT4 in specific involves the integration of team knowledge and experience, and most importantly, respecting the priorities and preferences for care at the patient level.
The pre- and post-outcome survey was used with written permission from Wake Forest School of Medicine. 0 is no knowledge or confidence about this. 4 is I consider myself to be very knowledgeable or confident about this. And 2 to 3 is about the average. So in the blue box is the College of Medicine. The red box is the College of Pharmacy. And you'll see pre on the left, post on the right. And this was the question, understand social, economic, historical, political, psychosocial, cultural factors. And you can see an improvement there. And it links back to each of the IPEC core competencies. Confident in my ability to work effectively with the medically underserved. And this one was about the same due to their experiences throughout their curriculum. Familiar with community resources available to assist underserved populations, we saw a vast improvement. Ability to communicate with and assist people with different needs. Cross-cultural communication and language skills for health, education, and care. We saw a slight improvement. Engage with community, public health to reduce disparities and promote health. And again, we saw a great improvement in this one. Negotiating plan of care with underserved populations, including constraints and expectations. And we saw a good improvement here as well. Knowledge skills to detect and address medical problems for underserved population. There was a good improvement here. So in the quantitative summary, we have increased self-reported knowledge and confidence post-course. Changes pre to post were mirrored for both groups of students. Top 3 areas where we saw the largest improvements, if you'll recollect, I am familiar with community resources available to assist teams that treat underserved populations. I know how to engage with community public health to reduce disparities and promote health. And I have the knowledge and skills to detect and address medical problems for underserved populations. The fun part of this is the qualitative themes. New insights on population disparities in the metro state, importance of advocacy for healthcare policy change, gaps in curriculum met, reinforced by selective content, connections of content to bedside care, such as trafficking cues, personal impacts of socioeconomic factors on care and health, personal insight on lack of health screening, such as assumptions and bias, patient professional advantages from interprofessional care, an appreciation for interdisciplinary approach, such as the interprofessional social history. We're going to show some specific examples of these as we found them to really bring great joy to Dr. Dennis and myself. To be honest, I have never been the type of person to focus on public health. I know that it is an important part of being a physician, but I never took the time to look into it or learn about it. These readings were some of the first I have truly taken the time to do that. To describe it all as eye-opening would be an understatement. Specifically looking at healthcare in Oklahoma County and in Oklahoma in general broke my heart. First and foremost, I just want to express how happy I am that I chose to take this course. I genuinely wish the things I learned in this course were integrated into the medical school curriculum, and I am quite surprised that they hadn't been yet. Thank you for creating this selective for the students. Throughout my 3rd and 4th year of medical school, I have seen how power dynamics and poor communication between providers has led to preventable adverse outcomes or delays in patient care. It may seem like a simple concept, but working with other providers is not easy nor obvious. We do not have much exposure with working with individuals from other professions. So when we are thrown into a clinical setting and expected to know what to do, it can sometimes be a disaster. Reading about interprofessionalism and engaging in it during Unity Clinic has been a wonderful experience. Learning about other professions and knowing how they contribute to a patient's care is so vital and allows for a more cohesive team dynamic. It is truly heartbreaking to see that race continues to be a factor that leads to differences in quality of care. Growing up with immigrant parents, I witnessed how socioeconomic differences negatively impacted the care they received and the consequences that have ultimately contributed to their poor health condition today. I am saddened but angry that access to quality medical care has yet to be a fundamental right, not just for U.S. citizens, but for every human being on this earth. Throughout my I am forever grateful for multidisciplinary resources such as social workers who can help in these delicate situations. We have a shout out to social work. As an Asian person, I have always felt weaponized against other people of color. People would often misrepresent Asians as model minorities and use my ethnicities as an example of how we were able to overcome disparities, so other people of color should be able to as well. Surrounding OU medicine is a variety of middle and low income neighborhoods, and no doubt the history surrounding the area is responsible for its demographics. Federal and local policies contribute to disparities. I had no idea that in the Jim Crow era, people of color were relegated to areas of town that are currently called Deep Deuce and Bricktown. We have been screening patients for a good portion of these health factors during the initial H&P. However, we have not been screening for additional health factors. Luckily, healthcare is a team sport where gaps in time can be taken by others. The improvement in the social history and other health factors would greatly impact the plan. In regards to plans to change OU Health with a QI project, one can definitely be started here. I would find it interesting if one were to have an interdisciplinary team planning sessions to try and see which health factor disparities there are in the majority of OU's patient population and brainstorm ways in which we could help to minimize this gap. And it sounds like we have a charge to bring something back next year. Finally, we'd like to thank the collaborating colleges and individuals who are listed here. Without them, none of this would be possible.